Dental care is more than just care for your teeth.
There is a direct correlation with our oral health with also systemic health. Maintaining good oral health prevents heart attacks and strokes. There's this bidirectional relationship with diabetes. There's also correlation with healthy pregnancies in terms of gestational weight and preterm labor.
We know that dental disease is a communicable disease. Periodontal disease can actually spread, as well as the bacteria that causes dental caries can spread in communities. So keeping one person healthy actually keeps more people around them healthy.
Having all of your teeth intact really plays an important role with the ability to eat. And especially with some of our traditional foods in like our community, we eat a lot of deer meat, a lot of salmon, sturgeon, eels, a lot of acorns, and that's kind of our main diet. But if you don't have all of your teeth to be able to chew, especially meat, deer meat or dried meat, that really can affect the type of nutrition that you're taking in as well. That also can take a toll on you mentally because our culture is part of our medicine.
It affects your sense of worth, your social life.
If my teeth don't feel good and they're rotting and they smell bad, I feel like I'm verge of losing them, they don't look good, I'm not gonna be able to talk to you. I don't even wanna go, I'm too embarrassed.
And of course you face the world with your teeth. You need to be able to eat well and smile well and function with their lives and apply for a job and keep a job and find love.
They're too self-conscious to apply for a job. I don't want to get a job because I know that I need to get my teeth fixed. I need to get my teeth fixed before I apply for this job. I hear that so often.
Whether or not we want to say that we don't look at a person's physical appearance, it does affect how people view them in the employment world. So having clean teeth, all of your teeth in place, really impacts a person's future and their long-term outcomes.
Their mental health is really closely tied to having a good smile to present to the world.
Overwhelmingly, there is more dental disease out there than any tribal clinics can fully manage. I don't know of any tribal clinics in California that are able to effectively meet every person's needs in the community.
American Indian children experience the highest incidence of dental decay compared to all other groups of children across the country. There is a lack of dental care in most areas of tribal communities throughout California.
I've worked here 22 years, and as long as I've worked here, it's been an issue. Part of it's being rural, retaining and attracting dentists to the area isn't easy in general.
For example, in Humboldt, there's between 132 and 133,000 people, and we have about 35 to 40 dentists. So doing the math, that's about 3,600 patients per dentist.
People just aren't willing to move to a rural community and then stay in a rural community. We have a handful of very special dentists that have been able to do that. There are not very many. We built a clinic to be able to provide access to dentistry, and once our clinic was finished, we had an empty clinic because we couldn't recruit a dentist to fill the space.
I think in all rural communities in general, the pay obviously is lower than in urban areas and in private practice. The amount of debt that new graduates have these days, it's enormous. These new graduates are going to have to take jobs that pay a lot more. Another factor is professional isolation, spousal opportunities for employment.
We have providers that will come, but then they leave because the lack of dental services. We don't have preventative services. We have emergency services. Our dentists are burned out at a rapid rate, and it's difficult for them to constantly see patients that are in pain.
In our area, we have dental programs, but when we don't have enough dentists, that affects accessibility because you can't get an appointment.
There's some offices where they're booked out 3-4 months. And then this little cavity that could have been filled now becomes an abscessed tooth.
It's quite shocking when they see the severity of the dental need here. They don't just need a little tiny filling or a cleaning. They have extensive treatment plans.
When I was in private practice in Los Angeles, I had never seen anything like this. It was a big shock to me. I was told about it, but I didn't believe it.
I grew up in what we call the village of Watek, which is way down the river on the Klamath River.
The nearest gas station store is at least 21 miles away from our home, along a one-lane highway mostly, and we just recently got electricity. So we're a little hard to reach community.
And in order to access dental care, you have to drive at least 80 miles out to Arcata, which is a pretty significant long drive.
That's just if you have a car. If you don't have a car, you have to walk or hitchhike or get another way of transportation.
A lot of our tribal members live in poverty, and the finances are an issue for them. Transportation's an issue for them. Dental insurance is an issue. Getting time off from work is an issue.
So a lot of states across the country have faced these same issues, lack of access to care, a provider shortage, and a really interesting, innovative, indigenous-led solution is dental therapy.
Dental therapy really started in New Zealand over 100 years ago. It was found to be so effective there that it's now common practice in over 50 other countries.
So a dental therapist is a really focused provider. They do a lot of routine preventative and basic restorative care to provide holistic services to their patients. You can really think of them as the nurse practitioners of your teeth.
The dental therapy scope is very, very specific. It includes some of the procedures that are the most common procedures that we do in dentistry. So while it might just be a small subset, it's about maybe 10% of all the codes that a dentist can technically provide. It is a very, very important subset.
Dental therapists provide the most commonly needed dental procedures. In general, dental therapists can do dental exams, the simple cleanings, all of the preventive care like dental sealants, as well as routine procedures like fillings and even simple extractions.
The thing that stands out the most about dental therapists is their mission for underserved communities. They are thinking about bringing access to those that don't have it.
These are mid-level providers, so the scope of their practice is very limited. And the scope of practice allows them to take care of patients who are urgent. If somebody, needs antibiotics, for instance, because, there's a swelling, something is happening, this is opening up access so that things don't get worse.
Dentists in California would benefit from working with dental therapists. It gives them the opportunity to meet the great need that they want to meet, that they desire to meet, and we've seen that in other states that have had dental therapy for a long time.
Dental therapists function a lot like a physician assistant, or also called a physician associate. The way that physician associates work in the medical team is very similar to the way that dental therapists work in the dental team. They can take care of a lot of the procedures that dentists might typically be spending a lot of their time on, but dentists have a lot more advanced training and can do a lot more. So freeing up the dentist allows the dentist to practice, as we say, at the top of their scope.
Much like we've seen with advanced practice clinicians on the medical side, it is a team-based approach. I would say that the dental therapist is like the wide receiver, of the team, where they're not always calling the shots, but they're making the plays. That is really bringing home the effectiveness of the dental program.
There will always be a place for hygienists, dental therapists, and dentists. They each fit a unique role in the dental or oral health landscape.
In my experience, when a dental therapist is added to the dental team, everybody's able to work more efficiently. The dentists that I know, including myself that have supervised dental therapists, have said, I would never want to go back. I love having this person on my team. They're able to provide so many of those routine services and freeing up the dentists to focus on those more advanced procedures.
There's like root canals, there's implants, there's dentures, there's so much more that we do as dentists. If we went to dental school just so that we can fill cavities, then it wasn't worth it.
Went to a meeting in Alaska. So I actually got to meet the gal that actually went to New Zealand for the training. It was awesome. She was unbelievable. I came back and made sure that our clinic was aware of it.
It was amazing. They were so excited about what they could do.
When the concept first was introduced in Oregon, I was curious. I wasn't sure what was going to happen and what that meant, but I mean, the same sort of conversations happened in medical when PAs came around, and now I don't think you could go to a medical office and not have a PA.
For me, it was kind of familiar because, like I said, I'm from Nigeria. So we have people called dental therapists in Nigeria. And in Nigeria, we're patterned after the British system. And I know that there are mid-level providers like that in the UK and Australia. So I kind of already knew about it, but it's very new to the US. As a dentist, the question was, well, how does this fit in? What are they going to do? What will be their scope of practice? But the more I thought about it and looking at the medical model of how medicine has moved and progressed, my thought was, we as dentists either get behind this and help navigate how it gets rolled out and make sure that the training is adequate, for the people who would take on these roles, or we'll get left behind.
Dental therapists are educated at the same level as dentists for the procedures they provide. So a dental therapy program is one less year than dental school. As the accreditation standards mandate, a dental therapist is learning a small portion, probably about 50 procedures, compared to hundreds of procedures that a dental student is learning in just 4 academic years.
I personally believe that even in our program, being at an associate's level with the least amount of barriers and the most efficient pathway, we have 3,400 hours of education in our program, 1,600 of which are clinical. That's a significant amount of time dedicated to the scope of practice, which is significantly less than a dentist. And to me, that's a huge reassurance, because when they surveyed dental schools, there were some schools that had less than 1,000 clinical hours in their education programs.
They're regulated by an accrediting body, which is important, and they're supervised by dentists.
There was part of the training where I had to be in the room the whole entire procedure and observe and check pre-op, prep check, post-op. You don't get that kind of one-on-one training in dental school typically, like a little bit, but not all of it. And I felt like the training they got was a lot more one-on-one focused training.
That's one really special piece that I really love so much about dental therapy, is that it not only was a non-traditional education program, and when I say non-traditional, I mean in the way that the United States education system is set up. It is not set up to make everyone succeed. It's set up to weed people out, and the dental therapy education program is not like that. The program that I attended in Alaska was 3 academic years consolidated into 2 calendar years. One of my instructors, Dr. Schofstall-Cohn, she had called me into the office and she was like, I can just tell that you need a little bit of extra help. And really what they taught me was how to study. And I didn't know that I didn't know how to study. It was like a light bulb went off, and after I was shown different tools and different things to help me to study better, I really started excelling a lot more. So that's what I mean by this program is not meant to weed people out.
We tried to keep our program to have the least amount of barriers so that we could recruit the most amount of students, particularly students from underserved communities. And we had the opportunity, as dental therapy education is a new profession, to not make some of the mistakes that might have been made in other educational programs. Those are things sort of like stacking a lot of maybe unnecessary science courses. So instead, when these programs were created, we created the science courses that teach to the CODA standards for the profession. So we take what maybe a college student might take for a traditional biochemistry course, and we combine that specific content that they need to become a dental therapist with their histology or their anatomy. So it's specifically tailored to the needs of this profession rather than taking a blanket course. CODA educational requirements say that our faculty to student ratios need to be 1:6. And so we use that to our advantage, and that gives the opportunity for a lot more one-on-one instruction to bring the student up to the level that they need to be in a shorter time frame.
The DHAT training can be anywhere from 2 to 3 year program. That is a length of time that a lot of people can commit to. By training people who are already happy in your community to become therapists, you actually are able to have more continuity of care because those therapists are more likely to stay in that community. As well as people know you. You're a part of that community. It's likely that people will be able to come and get the routine care that they need by someone that they know and they trust.
I resonate with our patients. They're my community. They're my aunts, they're my uncles, they're my cousins.
It's also important to talk about cultural competency. A lot of dental therapists come from the communities that they serve, and this really matters in rural California, where providers are coming from the cities and suburbs. They're staying in rural communities for exactly as long as it takes to get their student loans repaid, and then they're out of there to private practice. Versus a dental therapist who comes from the community, gets educated, comes back home, and serves in his or her community for their entire career. So it's a good pathway to both providing oral healthcare in places that don't have reliable dental care, and it's also a pathway to a good paying job for folks in communities that struggle with high unemployment.
A really neat thing about the legislation in states that have allowed dental therapists is they authorize dental therapists to work under what we call general supervision. That means that the dental therapist doesn't always have to be at the same location as their supervising dentist. So dental therapists are able to provide care in the clinic, and very importantly, we see that the dental therapists can be out in the community, in community locations, so we see them in schools, on mobile dental vans, or even in long-term care homes. Anywhere that the care is needed, we're able to bring the care to the patients, and that provides such an important piece of increasing access to care.
I've actually witnessed our dental therapists in action out in the community working from our mobile units.
It's not as easy sometimes to send our dentists out, so dental therapists is just like this natural choice. It's like an extension of the dentist.
They are actually providing care in our school-based health centers. We used to have a model where we provided care with a dental hygienist. And unfortunately, with the dental hygiene model, we were often having to have those patients referred back into the dental clinic. So by being able to now have a dental therapist on site at the school-based health centers, that increase of scope is particularly helpful. I would say probably about 80% of the procedures that are needed by that age group can be accomplished by a dental therapist.
The other place we've been able to utilize them is on our mobile vans in migrant and seasonal farm workers, and we go out in the summers to different vineyards and camps and provide medical, dental, and pharmacy services.
Our therapists are not out there on their own. They're tethered to our dental teams.
The dental therapist is supported by the dentist that they have a collaborative agreement with. We are available to them at any point when they are working externally. They can communicate with us via text or Teams. I'll say the vast majority of time they don't need our support.
When we're working with off-site supervision, each dental therapist has a collaborative agreement with multiple dentists. Any one of us are available via our electronic health record, or they can call us on our cell phone. I can look at x-rays wherever I'm at to help with any questions. They don't have a lot of questions, but I think it's helpful for them to know they have backup.
We include dental therapists as part of our peer review. So the dental therapists are being reviewed much like we review a dentist. They are included in other audits from outside agencies as well.
Every quarter, there's a certain number of my charts that will be reviewed by a dentist. And so feedback is provided based on documentation, x-ray review, and patients are a good gauge of like how successful we are. We've never had any complaints with dental therapy care that's provided.
We are very excited about the dental therapy program as a way to reach our most vulnerable members of the community providing comprehensive services in a cost-effective way.
The codes are completely reimbursable. We get our encounter rate. We are able to reimburse for that subset of codes that, that is within their scope.
I think if we add dental therapists to the workforce, there could be many dentists in California that may have never considered taking Medicaid patients that are now able to take Medicaid patients because of a dental therapist.
Fewer than a third of dentists in California accept Medicaid patients because it doesn't financially make sense for them to do so. But a dental therapist is a more efficient workforce model, and they're able to work with the Medicaid population and see Medicaid patients in a cost-effective way.
By adding some of the more routine, preventative type services that a DHAT would provide, it really promotes the specialty, higher level, higher paid providers to see the more income generating claims. Well, that should accelerate the financial gain of the firms, specifically private firms. Why wouldn't you want to use a less expensive force that enhances and creates more volume? And that's been proven in the other states.
And then I heard back in Michigan that another dentist who did this. He was very excited because it increased his income and his practice tremendously.
What I would ask is that people do the research, that people look at other states. There are many states that have the DHAT program, and they are being run very successfully.
In order for the dental therapy program to be implemented in the state of California, it literally takes state support. So we've seen Alaska engage in that with the Alaska Native villages and governments to high success. It's critically important that the needs of tribes and their approaches to delivery of care is built in and supported, by the state of California. As a part of that process, of course, tribes in California must be assured that the state of California will engage in government-to-government consultation and collaboration and coordination.
We need that collaboration, and that's what we're working on now, to get the legislators on board.
Educating all of our leaders, all of the legislators about what DHAT is and what a positive thing that could be for the community.
There are a number of other communities across California, non-Indian communities, that are in need of access to dental therapy. And so as we drive forward, partnership and unity and standing together will be very important to do, working with other non-Indian community-based organizations to encourage them to educate their lawmakers.
Dental therapy is an indigenous-led solution, but it's important to know that dental therapists can and have had a huge impact in non-indigenous communities as well.
To me, the dental therapy model is it's just like a no-brainer. It should be a legislative dream. This is a great educational model and a great solution to a lot of the issues we're facing in oral health care.
It's important to get in touch with your state representative and your state senator and tell them that you support bringing dental therapy to California. I would encourage tribes to join with the California Rural Indian Health Board to continue tribal advocacy for dental therapy in California. I would also encourage tribes to join the great folks at COHEC, the California Oral Health Equity Coalition. They're really leading the fight for dental therapy in California.
I don't think there's a good reason not to have this kind of provider in dentistry. There are not enough dental providers, and why not give an avenue for people to help their communities and help with the basic needs that everyone should have: dental care and a healthy mouth and no pain. We need to do better for our people and give them options for healthcare.
There's really no reason why in 2025 in the United States someone should end up in an ER because of a dental abscess. There's no reason.
A rural mobile dental van, that would be like fantasy, amazing, awesome.
I'm so excited to see legislation moving forward in other states to get this desperately needed workforce out into the communities.